Live, 7 o'clock. 7 o'clock. Audio's on. Visuals on. Clear for takeoff. This is happening. It's real. It's the 25th of February 2020. Good evening to you. If you have any questions, please feel free to chip in and ask me, and I will go through the questions I've got already. If you don't, because I've got lots of good questions already, but if you do, I'm always open to comments and suggestions. When you say I, who are you talking about? Well, what we're talking about is I being me, Jonathan Staiano, consultant plastic surgeon, and the director of the Staiano Clinic in Edgbaston in Birmingham. That's who I am. And what you need to do at this point is do what that says on the screen, which is right there. Please comment and share. Feel free to comment. Feel free to share. Feel free to just watch and neither comment nor share, whatever you fancy. Pretty open here. You can do whatever you want, really. No rules apply. Comfort your own home. You can, do what you want. Free country. So I'm going to kick off if that's okay. Hoping the audio is working. Should I 2 on 2? Is the audio? Okay, I'm going to assume the audio is working. Is that a fair assumption? Because a couple of times it hasn't worked. I should have someone in another room. 2 on 2. Okay. Tell me if the audio is not working. Oh, it doesn't work, does it? You won't know if the audio is not working. Anyway, we're assuming yes. That means the audio is working, presumably. Okay, right. Implant rippling. Do I need to change my implants? I had a breast augmentation 20 years ago. I have silicone implants. Wait a minute. Are these the right questions? Yes, I think they are. I had silicone implants placed on top of the muscle. I can feel slight rippling at the top of the breast, but this has been like this for about 15 years and hasn't changed. Do I need to think about changing my implants? So, no, you don't need to think about changing your implants. A lot of people worry about implants and when do you need to change your implants and what is the indication to change implants. Really, most indications to change implants come from patients rather than the doctors. We're not really likely to tell you that you need to change your implants. If you need to change your implants, it will come from a problem that you are having with your implants. So if you're not having a problem with your implants, or if you've got a problem with your implants that's been going on for 15 years and nothing's really happening and it's just the same, you don't have to have your implants changed. So you don't have to have your implants changed. Now, you might want to have your implants changed if you want to sort out the rippling and what have you. We can talk about how to sort out the rippling. But if you're asking, do I need to have my implants changed? Then the answer is no. You don't need to have your implants changed, even though you've had them in for 20 years, which is great. So if you've not got a problem, if you've not got a swelling, if you've not got a lump, if you've not got a hard implant, which is uncomfortable, then you don't need to have the implants changed. Now you might say, well, I've got a problem, I've got rippling. I'm like, okay, well you could have your implants changed if you want to. The problem with rippling is if you have an implant, if you have an implant, if you look at an implant, all implants ripple to a degree. And the question is whether you can see that rippling or not. So if you see the rippling, it's usually a combination of implant factors and patient factors. So implant factors can mean how well filled the implant is, how liquid the gel of the implant is. So obviously if the gel of the implant is more liquid, then that feels softer and feels nicer, but it's more likely to ripple. Whereas if the gel of the implant is more solid, then it's less likely to ripple, but feels a bit more firm. Modern day implants are slightly more firm than older implants. So your implants are 20 years old. The gel in your implant is probably less cohesive than the ones these days. a bit more runny than the ones these days, which makes it a bit more prone to rippling. But as I say, it makes it feel a bit nicer because it feels more squishy. So it's related to the those are the implant factors, and then there's patient factors. And patient factors basically means how much soft tissue you've got over the chest, how much soft tissue you've got to hide the implant. So if you're very slim, then particularly if you can see your ribs, that's the sort of simple guide. If you can see your ribs, then you're probably going to be able to see the implant, given that you can't hide your skeleton. So if we put something on top of the ribs, if you like, then you're probably going to be able to see the edges of that. So then what can you do? In terms of improving patient factors, the first thing, if your weight's okay, then fine. But if you did want to put on weight, actually putting on weight's a good thing. Don't often tell people to put on weight, but certainly if you're very slim and but you might say, look, hold on a minute, I don't want to put on weight. We're going to say, okay, fine. But if you did put on weight, then it might help. Oh God, what's this thing going on? I don't really have this in here. If you did put on weight, that might help. Then that might help. The other thing we can do, sort of artificially putting on weight, is is injecting fat. So you can inject fat over the top of the implant. Would that obviously mean an operation to help with the rippling? And the other thing you can do is, you said your implants are on top of the muscle, change plane to underneath the muscle. So if you put the implants underneath the muscle, then that can give that layer, an extra layer of cover, only in the upper pole though, when you put it underneath the muscle. So laterally and inferiorly, the implant is not underneath the muscle. The muscle that we put it under is the pec major muscle, which only covers it in the upper pole, which is usually where the problem of rippling is. But if you have got some rippling at the side, that might still be an issue. So there are things we can do in terms of improving the rippling. First of all, maybe thinking about changing to an implant that's got more cohesive gel in it. Feels a bit firmer maybe, but less prone to rippling. Maybe we've got a better fill. What that means is how filled the implant is. So basically how much volume that the shell can hold versus how much volume is in there, if that makes sense. Does that make sense? So, you can have a 80% fill, which means that the shell can hold 300 cc's, but it's only got actually 80% of that volume in it, which again makes it feel softer but more prone to rippling. But anyway, you can change some implant factors, and if you've got a 20-year-old implant, it would probably be possible to change to a more cohesive one. So that'd be number one. And then probably the big thing is the muscle thing. So if it is on top of the muscle, changing plane to underneath the muscle would improve the rippling in the upper pole. And you may feel, I've had them in for 20 years, I want to have them changed, which is fine. But as I say, if you're asking, do they have to be changed, then the answer is no. But if you want them changed, you can have them changed. But the problem is, if you're very slim, it's always going to be a problem. People who are very slim, it's always going to be a problem hiding those implants. And sometimes look, you might see or feel a bit of the edge of the implant in terms of rippling or feeling the edge of things if you're very slim. We hear you. Precious says it's always good to hear my advice. Look at that. That's nice to hear, Precious. Thank you. It's always good to see your comments. Thank you. James, interested in narcotic-free tummy tuck due to wife having serotonin syndrome after first op. Oh my goodness me. James, that is on the list. We got you on the list, James. Should we do that one now? Let's do that one now. Oh Lord, where's my questions gone? Right, narcotic-free tummy tuck. Oh, that was the last one, actually. Okay, well, let's do that one now. Let's do it now. We can be mobile because James is here. Narcotic-free tummy tuck. Serotonin syndrome. Goodness me, what is that? So, James, this sort of thing is more the anaesthetist's arena. But in general terms, narcotics, opiate analgesia, they are good analgesics. They are good painkillers. But personally, I don't like them. I don't particularly like these sorts of drugs. The sort of drugs we're talking about is morphine and things like that, and the reason I don't like them is because they have side effects. The side effects being nausea, make you feel sick. So if you've had something like a tummy tuck, so I think this is, we're talking about a tummy tuck here. If you have something like a tummy tuck, I can imagine being sick after a tummy tuck. Not great. They can make you feel dizzy. They can make you feel woozy. They can make you constipated. Again, can you imagine being constipated after a tummy tuck? not good. Straining it, after a tummy tuck, not good at all. Um, so they have a side effect. So I always tell people to steer clear of opiates, certainly after the surgery in terms of post-op analgesia. So after the surgery, painkillers, I like ibuprofen, paracetamol. They're not opiate painkillers. Opiate painkillers are things like obviously morphine, cocodamol, coproximol, codeine, tramadol, these sorts of buprenorphine. These are opiate analgesics. So they do have side effects, and I don't like them. So Exhibit A, I always tell everybody, if you can, steer clear of them. Steer clear of them. Now you're asking specifically about having a whole tummy tuck opiate free. Now we can do tummy tuck under local sedation, local anesthetic and sedation. It's quite a big deal to do it under local sedation, and it's not for everybody. You can often feel bits and bobs, and you have to be on board because it can be a little bit uncomfortable, to be honest with you. Um, and it is usually better to do it under a general anesthetic, and often opiates will be used. Can it be done without narcotics? Is to use the sort of, it's a bit more word on narcotics, but we'll call it narcotics. Sounds a bit like sort of CSI, that, doesn't it? Sounds like they're bad drugs. Obviously they're the same drugs that get abused, but they are actually good painkiller drugs. So it can be done without opiate analgesia, but if you're asking, or if you were asking, I don't like the thought of them, sort of thing, I would say to you, yeah, definitely, me neither. Let's steer clear of them. But if you need them, we'll give them to you. If you're saying that your wife has a problem that she cannot have, I'm trying to think how serotonin syndrome would affect narcotics. Sorry, my how that I'm guessing that means there's some problem with narcotics with this serotonin syndrome, but that would be something more that we'd have to discuss with the anaesthetist, and we'd have to make a balanced judgment on it, because I've got to say, a tummy tuck's a big op, and if you were unable to have um, narcotics, then it could be done, but it might be a bit more uncomfortable, and we'd have to have a discussion with you about that. It also depends on how much, there are tummy tucks and there are tummy tucks. Sometimes people are very big. There's quite a lot of dissection to do, and it's quite hard to get local anesthetic in all the areas. Some people are a bit more slim, and they've just got that redundant skin, and so it's a bit more easy to anesthetize those areas with local anesthetic. So obviously, if you can anesthetize it with local anesthetic and give you some sedation and on top of that, then it's going to be less uncomfortable for you and less requirement for you to have um, other analgesia, um, like narcotics. So it's a tricky one, James, and I wouldn't like to guarantee it. I think it's something that I would say that we, or whoever's doing the tummy tuck, would need to see you, have a discussion with you, and the anaesthetist would have to be involved to get the anaesthetist on board. Not all anaesthetists are happy with doing local sedation, and even if the anaesthetist is happy doing local installation, how they feel about doing it where they actually couldn't use any narcotics, I'm not sure. We'd have to talk to the anaesthetist about that. It's a good question, and in your specific case, I'd say not sure. But in someone who was saying to me, don't fancy opiates, I would say, oh well, that's fine, me neither. We'll try and avoid them if we can, but we might have to use them, which is a slightly different situation to yours. So yeah, and it might, so it comes up to all this sort of surgery to balance risks versus benefits, and it might be that she might not be a candidate for a tummy tuck because it is quite a big op, and can be a bit uncomfortable to do the op. So might be. I'm not saying it will. Might be, but good question, James. Good question. Thank you for the narcotic-free tummy tuck question. Angela says hi. I'm going to say hi right back to you, Angela. And Lou, likewise. Precious is back in. I like you simply because you're very honest when people are asking questions. You don't hide. Keep it up. All the best. I don't hide, Precious. No, I'm just here in the limelight, in the spotlight, in the studio, living it. I'm living it, Precious, for real. So what's going on with the next question? I'll tell you what. What's involved in a thigh lift? That's what we're talking about here. I'm considering surgery on my legs. What is involved in a thigh lift? Are the scars large and visible? Actually, this leads on to the next question as well. Um, the scars for a thigh lift are vary. There are different ways you can do a thigh lift, and they are broadly speaking two types. One type gives you a scar up in your groin. And the good thing about that is it's totally hidden. It's hidden in your underwear, it's up in your groin, no scars on your legs, no scars on your thighs. And so that's nice. So when you talk to people, they think that scar is good and nice because it's hidden, which of course it is. And we're always trying to hide scars. The other scar for a thigh lift is a big long scar down the inner aspect of your thigh, all the way down to your knee. So a longitudinal scar all the way down your inner thigh, much more obvious. So, so your question: are the scars large and visible? Yes, they can be. If you have the type of thigh lift where the big scar down to the knee, yes, they are large and visible. If you have the type of thigh lift where it's hidden up in your groin, no, they're not large and visible. They're small and I wouldn't say invisible because they are visible if you take your underwear off, but when you've got your underwear on, they are not visible. So you might say, well, actually, I'll have the small and invisible scarring, please, which is not unreasonable. In my hands and in my experience, and this is, have I got my disclaimer? Disclaimer, this is just my view. Um, oh, there's a question I missed off. Um, this is just my view. So about disclaimers, that just reminded me. I feel in my hands that that scar, which is hidden up in your groin, is less of a tummy tuck. Well, it is less of a thigh lift. It is less of a thigh lift, and not I feel it is less of a thigh lift, and it's just not as good. It doesn't give you as good a lift. It doesn't take out as much skin. It can't take out as much skin. If the scar's smaller, it can't take out as much skin. The bigger the scar, the more skin you take out. Simple as that. That is, fact. You want a small scar, fine, but you can have less skin taken out. The bigger scars we make, the more more skin we can remove. So less skin is removed. And also, the main issue is the vector of pull. The vector of pull, because you're trying to tighten the skin around the thigh, the vector of pull is an upward pull. You're pulling up into the groin. You're tightening the skin in an upward direction up into the groin. And when you need a thigh lift, your laxity is in a circumferential direction, not in an up down direction. And so the thigh lift where you make a big long scar down the medial aspect of the thigh, the big visible scar gives a better thigh lift. No question about it. It gives more tightening, it gives a better result. And I prefer it. I prefer giving more tightening, better result. But I'll only do it on people, and I'll make it quite clear there's a big long scar down the middle of your inner thigh. We try and hide it so you can't see it from the front, can't see it from the back. But if you abduct your hip, if your thigh moves out, then you will see it. It's a big long scar, and people might see it if you're wearing short trousers or short dresses. So I think it is a better thigh lift, but it's more scarring and more visible scarring. So if that's a problem, you might want to go back to your thigh lift where there's a scar hidden up in the groin. But I don't think it's as good a as good a lift. The scar's got a risk of infection and what have you because it's up in the hot, sweaty groin, and it can cause its own problems. So I don't particularly like that sort of thigh lift. So I think it's the big long scar down the inner aspect of the leg, or well, nothing really for me. But I know a lot of people do the other one. But it's just not a great lift when you do that sort of scar. I think it's too much of a compromise personally. But it's all about being informed, a bit like the narcotic thing. It's all about being informed about the the pros and cons of making a decision. No one would do a bigger scar if they could get the same result with a smaller scar. No one would do a big visible scar if they could get the same result with a small invisible scar. So there's a trade-off. So, right. Tracy says hi. Hi, Tracy. Nice to see you. I'm right-clicking instead of left-click. Hi, Kellyanne. If you have a full tummy tuck, how far up the belly do you lift up to pull down? Does it get rid of your underboob rolls? Tar. Yes and no. Yeah. So you do go to the underboob rolls. Is the yes? Well, it's not really a yes. It's anyway. You do go up to the rib cage, basically, Kelly. You go all the way up to the rib cage when you. I have to find that other question I missed off. When you do a tummy tuck, you undermine all the way up to the rib cage, and you do mobilize all of the. Well, usually just a tunnel, but you do mobilize the skin of the upper abdomen and pull it down. But it is not great at removing under boob. If you really got proper under boob rolls, if you've got a bit of skin there and you're exaggerating by saying under boob rolls, then that skin will be pulled down and tightened. But it's a bit of an indirect pull. Most of the effects of a tummy tuck is in the lower abdomen, the bit from the belly button down. That is the bit that gets removed, and the bit from the belly button up then gets pulled down and gets tightened. And there's no question it is more taut. But if you've got a proper roll of skin under your boobs, that will not be addressed at the time of a tummy tuck. And that would probably need to be addressed secondarily later on with either liposuction if it's not too bad, but if it's a proper roll of excess skin, a reverse abdominoplasty where you take the skin out and make an incision under the breast. You usually do that later, 6 months or so after the tummy tuck, to get rid of those rolls. But that's really for people who've got massive weight loss. Which you may have, I don't know, but it's not for everybody. I think a lot of people feel that they've got a lot there, but they haven't really. And actually, when you have a normal full tuck, that can pull that skin down and indirectly tighten the skin under the boobs, but it doesn't sort of directly pull it. So yeah, you go all the way up to the rib cage and you pull it down. What is going on? I'm right clicking instead of left clicking. Right, SJ Small Page is in the house, everybody. The famous SJ Small Page, good to see you. Hello. Junie says, with the inside thigh scar, how much if a groin scar is there? With the inside thigh scar, how much if a groin scar is there? With the inside thigh scar, how Junie, is that a question? With the inside, so what you're saying is this groin scar's already there. So is this like saying you've already had that sort of groin thigh lift and you're going to go for the other thigh lift, which would be fine? Do you mean how much money or how much? So that'd be fine. If you've had the one thigh lift and it's not done the job, you could always have the big long scar down the median aspect of the thigh. So copy this question quickly. Yeah. Is that your question, Junie? Of a groin scar. With the inside thigh scar, how much if a groin scar is there? How much of a groin scar? Got it. How much of a groin scar is there? Yes, not much, Junie. Not much. Sorry. How much of a groin scar is there? So basically, it goes all the way up into the up into your perineum, which is up where your groin is, and there might be a little L, a bit like the arm. You get a little L, but not that. It certainly doesn't go up as high as the other type of thigh lift. So the question is, with the inside thigh scar, how much of a groin scar is there? Yeah. With the downward scar, you must need a groin scar too. No. No. So basically, you're taking out a lips, Junie. Right, let's get physical. You're taking out a lips here. So whoop, whoop, whoop. That skin is taken out. Yeah. Big long scar. So you don't have much of it. The other one has a scar here, and it pulls it up. Has a scar in there. I don't know if I'm going to get banned from Facebook from that. Surely not. Surely it's past the water. Oh no, it's not past the watershed, is it? No. So yeah. So Junie. So you might have a little groin scar, a little L up in the groin, but not much. I don't know. I hope that's answered your question, Junie. You think you must need a groin scar? Why must you need a groin scar? Good demo. Yes. Right. What's going on? Precious lost it. Right. Precious, pull yourself together, girl. Right. What's going on? We're going to go slick as you like. Similar vein. Similar vein. One stitch. I'm going to add an item while I'm here. One stitch facelift. Do you do it? Do you carry out facelifts at your clinic? I'm thinking about the one stitch facelift. Is this something you do, and what are your views on it? Does it last? So no, I don't do it. Is number one answer to that. But I can answer the question because I'm a plastic surgeon and I know about these things. So I don't do it. I mainly do breast and body is my thing. So I don't really do faces, but got a view. So basically, the one stitch facelift is a little bit like any of these minimal scar techniques. To be honest, a bit like the thigh. It's a bit like breast, mastopexies. People are always trying to do short scars and minimal scars, tummy tucks, short scars, and all this sort of thing. And it's the same principle. The shorter the scar, the less skin you take out. And the thing about a facelift is a full facelift, a full sort of full on facelift is quite a big op. No question about it. It's a big op. It's a lot of downtime and it's a big scar. And, it's a big deal basically. And not people, many people are not ready for it and are not ready for um, for the downtime, for the potential complications, for all the risks with it, etc., etc. So that's absolutely fine. So a one stitch facelift involves just hoiking and pulling up the face. It's a much more simple procedure. It's a local anesthetic procedure, much less downtime. What was the question? Is this something you do, and or how long does it last? Much less downtime, and very nice, effective. It's quite a popular procedure. I've got no conflict of interest because I don't do one stitch. I don't do full facelifts. I don't do any. So one stitch facelift has merits because it's much less downtime, short procedure, but at the same time, you can't expect it to be as good as a full facelift. Otherwise, no one would do full facelifts. And so it doesn't last quite as long. You're obviously not removing the skin that you're removing with a full facelift. You should see the amount of skin that you remove when you do a full facelift, and that skin gets removed and gone forever. This just involves sort of pulling up and anchoring the skin. So it's I think it's got a place. And I think if you haven't got much laxity and you perhaps don't need a full facelift, and particularly if you don't want a full facelift and are happy to accept perhaps not quite as much tightening as you would get with a full facelift, then and you don't want the downtime, you don't want the complications, you don't want all the problems associated with a full facelift, absolutely fine. So I think it's definitely got a place. But you have to take you what everyone wants to hear is that it's as good as a full facelift. They want to hear that, yeah, it's the same, you don't need a full facelift, you just and unfortunately there are people out there who only do well, there's some people who will only do one thing, particularly if they only do the lesser thing. If they only do the lesser thing, they might say, oh yeah, you don't want a full one, have this one, it's just as good. Well, why would anyone do a full one if this one was just as good? So, if you talk to someone who does all of them, they'll say to you, look, sometimes I do full facelifts and they're brilliant for these cases, but one stitch is brilliant for these cases. So be wary of anyone who tells you that they're just as good as a full facelift, because I don't think any surgeon would want to take on complications, scarring, big operations if they didn't have to. So the big operations do give more of a result, but come with them more complications and downtime, etc. That's answered that one. Oh, here we go. What, Michelle? We've got on the one. Oh God, started something now. We've got another question about the one stitch facelift. What does a one stitch facelift address? I've lost my fat pockets and have lines nose to mouth. Lost my fat pockets. So I think lines nose to mouth. Okay, so nasolabial here. This sort of Fat pockets, where are you talking about? Your lower eyelid when you're talking about fat pockets? So basically, if you're talking about sort of the fat pockets here, cheek, that's probably more of a mid facelift slash lower blepharoplasty. So it's different. So in terms of restoring and tightening up this area here, and sometimes people are now injecting fat. We used to be taking a lot of fat out of these areas. Now we're sort of injecting fat to sort of volumize the face. So a mid facelift is more, a one stitch facelift is more the neckline and the sort of jowl and sort of tightening the sort of jawline is should really be called a lower facelift, I guess. So the one stitch facelift addresses this area. The lower blepharoplasty slash mid facelift addresses this area through an incision in the lower eyelid, this bit here, and then your brow is and your forehead is a brow lift. Um, and your lines nose to mouth. Um, Lines nose to mouth, that could be helped with filler is an option for that sort of area. um, I'm not sure if a one stitch facelift would help your lines nose to mouth, your nasolabial, we'll call them nasolabial, shall we? But filler might be an option for that. But yeah, a bit out of my territory, Michelle. I hope that's helpful. That's an armchair view of it. You're better off talking to a specialist, really. I'm just, I'm just the cleaner. I just come in, picked up the microphone. Anyway, Lisa Halls. I've lost over 14 stone. 14, can that be right? In weight, and had an FDL last March, fleur de lis abdominoplasty, that is, which is like an inverted T-shaped scar for those viewers who don't know what an FDL is. It's quite a big abdominoplasty, basically. I'm now looking to sort my boobs out. I have lost all of the volume at the top. I'm currently 36 double D. Would I have just a lift or with implants? So, Lisa, if that isn't a typo, oh, you're saying congrats. Kirsty says congrats. And Lisa says, yep. So basically, that is not a typo, Lisa. You have lost 14 stone. Well, let's give her a hand, guys. Lisa's lost 14 stone. I bet people don't recognize you. Amazing. Wow. Um, so basically what you probably need is you need the volume redistributed, Lisa. So if you're a 36 double D, you've got quite a bit of volume there and you need it redistributed. So I would say you need a lift. You don't need implants unless you say you want to be an F cup or something like that. But I don't, and then if you start getting big, putting implant, if you've got fair volume already and you put implants in, you're making them heavier. The heavier they are, the more they're acted on by gravity, the more they'll droop again in the future. So I would say you don't need implants, Lisa. You need just a lift. Now, one thing I always clear to point out to people when they're having a lift is the shape does settle and it does give you a bit of concavity in the upper pole. You don't get that bulge you get with implants. So if people are adamant they want that bulge in the upper pole, then implants do give that. But the main thing about implants, they make your breast bigger. So if you don't want your breast bigger and you just want the shape addressed, just a lift. If you want the shape addressed, lift. If you want the size addressed, implants. Assuming you want bigger. If you want them smaller, then it's reduction. But implants are good at making them bigger. Lift's good at making the shape better. And it sounds like it's a shape problem with you, Lisa. Precious, what you got? I really want to do some liposuction, but I'm to die. Oh, I'm scared. Is that to die? Or butt fat transfer? I guess I'm not brave enough to do it. I wish I was because it's something I've always wanted. So, Precious, yeah. I mean, I don't want to be too inflammatory, but we're not supposed to be doing butt fat transfer. At least plastic surgeons in the UK are not because of the risk of death. I think in skilled hands, speaking to very surgeons who do a lot of these work, they will say that the risks are small and acceptable. But you have to be obviously sign the consent form at the end of the day, and you have to accept that risk. There's risks with anything. There's risks with any surgery, but they're small. And I think from what I am seeing that a lot of the problems are coming from people who are not experienced in the techniques and are doing it in an unsafe way. And there are safe ways to do it. So it may come back in. I think the plastic surgeons in the UK are looking into it and doing sort of research into it to see whether it's something that we can introduce back in. But at the moment, it is not something that we are doing. So yeah, it's not a question of brave enough, Precious. It might be best just to leave off for a bit, maybe, or at least seek out someone who's got experience. But it probably won't be in this country, unfortunately. Having told people not to go abroad for surgery, there's no one in this country really doing it, unfortunately. So Lisa doesn't want to be bigger. So Lisa, it's a lift then that you want, not implants. It's a lift. So yeah, this is the question here. Do I have any reference to non-disclosure in your contracts? This is a person who's contacted me who said that there's people who are doing these things that you have to sign when you go to surgery, saying um, saying things like uh, basically I don't know, I won't post on social media, I think it says, and I don't know, I won't say bad things about you as a surgeon. You know, you won't um, as part of the consent process. Um, so the answer to that is I don't have that sort of non-disclosure thing on the consent form. The consent form basically says this is what the procedure is. This is the anesthetic we spoke about. Um, I've told you all the options, including not having surgery and things like that. You know, and do you consent to the procedure? I don't ask people to sign something saying they're not going to go on social media and complain or say something bad. I don't know how well that would stand up. I'm not a lawyer. I need another disclosure here. I'm not a lawyer, and I don't know any legal ramifications of it. But I think if you are unhappy with your procedure, um, I don't know how it would stand up legal if you signed this form to say I won't, um, you know, put things on social media about it. I think in this day and age, we can't really stop people from putting stuff in social media. It's interesting. I was at a meeting a few years ago now, and very reputable surgeon said, "Oh, I had a bad review." There was a lawyer giving a talk, and I had a bad review, and tried to get the review taken down, and um, all this. And I was sitting there thinking, you know, unless the review is sort of defamatory, and get lawyers involved, it's hard to sort of get someone to remove something which might be true. I'm not happy with the result, and the surgeon didn't listen to me, and and was rude and abrupt, and I'm not very happy. That's sort of, if that's factual statement, it's hard to stop people from putting that stuff online. And my advice would always be try and build up as much positivity as you can, so that when the negativity comes, and certainly I've got to be honest, as plastic surgeons, we, and certainly I, do feel quite exposed, because anyone can say anything at any time. Don't even have to be a patient. They can just, anyone can post anything. I shouldn't give anyone ideas, but we are a bit to the mercy um, of people, and so I think we just got to try and do as good a job as we can, and try and encourage people to do um, encourage as much positivity as we can. This happened to me recently. I had a 1-star review on Google, which was very upsetting for me, because I had about 20 or 20, a bit more than 25-star reviews on Google. So if you Google plastic surgery Birmingham or something, 5 stars, yeah, it looks great. And as soon as you've got anything less than a 5 stars, you can't have 5 stars anymore. I can never have 5 stars. I get a million reviews. I've got one-star review, and that my average is always going to be 4.9, might be 4.999. But anyway, so that was very upsetting. I've got to be honest. Um, it was a patient 10 years ago. I did their surgery. So why they chose in 2010, why they chose 2020 to put a review. But I feel I actually sent an email to my patients on my database and said, look, I got this 1-star review. And then I, in a very short period of time, got about 20 5-star reviews. So I've now got 50 reviews, but I've got 52 or something. 51 of them are 5-star, and one of them's 1-star. But I think that's all you can do. You can just try and do a good thing, and hopefully do as good a job as you can, and please as many people as you can. But I guess you're never going to please everybody. And I think these non-disclosure things. I'm not sure whether it's going to come in, whether we're all going to be starting doing it. Maybe I eat my words. I've done it now. It's on video. It's out there now. I've said it, but we don't do it at the moment. Whether we will do it because some lawyer will tell us it's a good thing to do. But I think, in this day and age with free speech and social media, it's hard to make people not say bad things about you if you've done something bad, or if they perceive that you've done something bad. It's an interesting one. I was quite surprised to see that. Precious. Thanks, Diano. Yeah. You're welcome, Tyra. Lisa, I need to come and see you. I'm right here, Lisa. Lovely to see you. Narcotic free, 1 stitch. We've done that. Should I have smooth or textured implants? Let me just see. Now, I've done the other two. So, fair warn, this is the last question, guys. All in, fair warn. So get them in, get your thinking cap on, get in the comment section and get busy if you've got a question for me. But don't worry, I'll be back next week. If not, if you don't get it in on time. If you're watching this on the replay or on the podcast, let's not forget this is the podcast every Tuesday. Oh no, we don't post it. I don't know when we post it, but anyway, it's a podcast on iTunes and any or SoundCloud. So if you've got those things and you want to listen to me in your car, then just do it. Just download the podcast. Why not? That's what everyone's doing these days. Now, this question, very fond of this question because it started #AskJJ. I knew we could get that hashtag trending. That's what I'm talking about. Right, #AskJJ. This is just a question for Tuesday's live. I'm having breast augmentation in April and I'm undecided on the type of implants to have. My surgeon uses Nagor implants and mainly uses textured impleo. He told me about the recent findings with the textured implants and a certain cancer. Oh God, it's cut off the rest of the thing. Oh God, what was it? I originally opted for the textured, but he said he will also have the smooth in. So on the day of surgery, if I change my mind, he will use the smooth. I'm just so undecided, and I really don't know what to do for the best. My surgeon told me that there is a higher risk of capsular contracture with smooth implants. I'll be having my implants placed under the muscle, and recently read that if you have smooth under the muscle, the risk isn't as high as if you would have them over the muscle. There's just so much different information about that. I'm just so confused, and it really is causing me a lot of worry. I'd really appreciate your advice. My surgeon said he's concerned about the textured implants and he has been using them for over 25 years with no issues. But he said ultimately it's I think that should be choice. Missed out the last word. Oh, yeah, sorry, no, I haven't. It's my choice, but he wanted me to know all the risks involved. Thank you so much. Few things to wheedle out there, isn't there? First thing I would say to you, my advice, and again, this is my advice, and who am I? Your surgeon is the main man/woman. So, but you've asked for me to put my oar in, so my oar is going in. First thing I would say to you, I really don't like doing anything on the day. So personally, I don't like the thought of making a decision on the day whether you're having smooth or textured. I would make the decision before the day. You've got enough on your plate on the day of surgery to be worrying about. You've got to make a decision, on the day whether you have, smooth or textured. I think when people start making decisions on the day of surgery, I would normally say, look, let's postpone the surgery. Let's do it another day because, it's not good practice, I don't think, to making decisions on the day. So the first thing I'd say to you is I would try and make a decision before the day, number one. Number two, yes, true about capsular contracture under the muscle. So capsular contracture is measured by how much you can feel the implant, whether you can see the implants, and whether it's painful. That's the sort of grading of capsular contracture. So grade 1 capsular contracture is you can't see or feel the implant. So everybody in the world with implants has got grade 1 capsular contracture. So grade 1, everyone's got that. So if you can feel the implant but not see them, you've got grade 2. If you can see them, if they're starting to contract and see the edge of it, it's grade 3. And if they're painful, then that's grade 4. So the muscle over the top of the implant sort of protects the implant. So you're less likely, or it's going to take longer before you can see it, and it's going to be longer before you can feel it because you've got that muscle over the top of
So you're absolutely right. So capsular contracture presents later in patients with implants underneath the muscle, or any type of implant underneath the muscle. So that's one benefit of having the implant underneath the muscle. But nevertheless, smooth implants do have a higher risk of capsular contracture when compared to textured implants. So this ALCL is a worry, and it is a concern, and it is a type of cancer, and it is associated with implants, and it's associated with textured implants. So that is what this issue is about. So textured implants are associated with ALCL. So there are some surgeons, and it sounds like this surgeon might be one of them. Some surgeons are moving towards smooth. Well, this surgeon's giving you the option, but some surgeons are moving towards smooth implants because they say, "Listen, I don't want to give my patients ALCL, which has got a risk of death, um, and I'm going to go smooth implants." And you might think that sounds absolutely reasonable. Now, my view is that there are bad things with smooth implants. So there are risks with having smooth implants, and there are risks with having textured implants. And the evidence is all a bit, there's not a huge amount of evidence at the moment because it's all quite fresh. This it's only in the last few years really this ALCL has been coming out, um, and the numbers are small. There's not that many patients who have been diagnosed with it. It's a very rare type of cancer. It is not breast cancer. So breast cancer is a very nasty disease, and it's got a very poor prognosis, or at least certain types have, and it's a huge problem in the world. This is a lymphoma. It is not a breast cancer, and it's a cancer of the capsule, the scar tissue around the implant. And the majority of cases, when caught early, and there often are caught early because there's often the symptoms associated with it, there's usually a lump or a swelling, um, are cured by removing the capsule. So it is a curable cancer if you remove the capsule and you catch it early. And so the risk of dying from ALCL, excuse me, is very low. There was a study a while ago where they looked at the risk of dying with having certain things, and they said if you go to New York for 2 days, if you go skiing for a week, your risk of dying is twice the risk of dying if you have um, breast implants in, texture breast implants in for life. So, you know, when you put it like that, if you said to me, "I'm going skiing next week," I could not guarantee that you wouldn't die. People die when they go skiing. People die when they get in their car and go up the M42. So there is risk of death with these things, but we accept that risk. That's an acceptable risk. So you've got to put it in perspective. The risk of dying is extremely small. Um, and the risk of having smooth implants is their increased risk of rippling. That's why you pretty much always have to put them underneath the muscle. You can't have a teardrop shape because they move, they don't really adhere, and capsular contracture is increased, and so there's more risk of having capsular contracture and a potential for another operation in the future if you did get a capsular contracture associated with that. So it's about putting it in perspective, and the main thing for me with this sort of thing is patients being comfortable in their own mind as to that they're making the right decision. Because at the end of the day, there isn't a right decision, to be honest with you. You've got to be the right decision for you. Some people will want smooth implants, some people will be happy having textured implants, and it's just making the right decision for you, and it's balancing it up. If there was a right decision, we'd all be doing it that way. Now, there are some countries that have banned textured implants, France, Australia. Um, I'm not sure about that because I do think there are benefits with textured implants, and so I would say it's better that we give people the facts to allow them to make a decision on the balance of risks, because there is a balance of risks with both. And it's interesting. I spoke to a reporter a while ago and said, "Oh, women are dying with these implants, and it's awful that we're giving our women these implants, and they're dying, and it's terrible." And I think that's a bit of an inflammatory way of putting it. It's a bit like saying, "Oh, well, women are dying with this skiing things. People are putting these flat things on their feet and they're sliding down snowy mountains. It's disgusting. We shouldn't be allowing it. We should be banning skiing." I'm like, well, let's not ban skiing. Let's just let people know that there's risks associated with doing these things, and let them decide whether the benefit of going down the slope with these flat things on your legs is outweighs the risks. So the risks of dying are very small, and it's good fun going skiing. So, let's let people make a decision as to whether they want to take that risk or not. And a lot of people do choose to take that risk. Um, But anyway, that's my view on it. So I think either would be fine, and I think you really need to work with your surgeon. And my advice would be don't make a decision on the day, make a decision beforehand, and whichever you have, be happy with the decision that they've both got pros and cons. So if you get a pro, or if not a pro, if you get a con of one of them, just accept, okay, well, I knew there were cons associated with it, but just remember there were pros associated with it as well. Don't think, oh, I made the wrong decision because I got this con. I used a smooth implant and I got a capsule contracture. Oh, I should have gone for a textured. Well, no, remember you went for a smooth because you were worried about the risk of ALCL. So that was the benefit. So the fact that you got a con, well, that you always knew that was a risk. That's the way I would be approaching it, trying to make the right decision for you by um, weighing up the pros and cons and what people want. And people want this when they're choosing implants. They want the right choice. They want the perfect implant. They want the best implant. Everyone says, I want the best. If there was one best one, we'd all use that. There are good and bad about round, textured, high profile, low profile, polyurethane, macro textured, nano textured, smooth. There's all different types of implants, and there's good and bad about all of them. There is no one best implant, unfortunately. Otherwise, we'd all just use that one. So it's about making a decision for what's right for you. I went to sleep on that one, haven't I? I'm on a bit of rant there. That was a bit of a rant. Sorry about that. So I hope that's been helpful. And Precious, I hope I've been, what did you say? Honest. Yeah, honest, not hiding. Yeah, face it head on. So that is a wrap. Unless anyone's got a question, I'd be very happy to answer. I can sit here for a bit, not got anything to do. Oh, crikey, got a question. Hold on. Well, one's come in. We've got a question come in. Right, Jane, thank you so much for answering my question. Right, you have given me some great advice, and I feel so much better now about what decision to make. So thank you. Good, Jane. You talk to your surgeon, and as I say, make a decision prior to surgery. It would be my advice prior to the day. I never think it's good doing things on the day. And yeah, good luck with that, Jane. I'm glad that's been helpful. That's nice to hear. Well, thank you. There you go. So, oh, that's good. That was worth the wait. Um, that would have been annoying if I cut it off just so typing that in, wouldn't it? So I am, well, on that note, that's very kind of you to say that, Jane. Good luck with everything. Good luck in April. I'm sure it'll be fine. I'm sure it'll be fantastic. Whichever type of implant you choose, you can get great results with smooth. You can get great results with textured implants. So you're going to get a great result. Don't let it mar your um, view of the whole thing. You try and stay positive about the whole thing, whichever one you choose for. Choose. So yeah, Stiano checking out. Thank you all for visiting and watching. And I will be here at 7 p.m. next Tuesday. So please get in there. Do like what Jane did. Ask me a question. Loving it. Loving the questions tonight. Keep them coming. And I will see you here next Tuesday, and I'll be answering the questions at that time. So for me and for everyone here in the snug, it's good night. Good night.